So good night, everyone, and back to our Wednesday didactics. It's 9 p.m. exactly, and today we are lecture 22. Lecture 22 in the endometrial cancer module. We are going fast and fast in the endometrial cancer module. It's going to be finished next month. Today is a very interesting topic by a very interesting surgeon and a very eminent surgeon, Dr. Khaled Gaballah, Assistant Professor of Surgical Oncology, Oncology Center, Mansour University. He is now very well known for every gynecologist in Egypt and for many gynecologists and surgical oncologists all over the region. Dr. Khaled has been trained and he had his fellowship in Gemelli Hospital in Rome, Catholic University in Rome, with Professor Scambi and Professor Anna Fagotti. And then he came back and he was a great step for the introduction of gynecology in our center, Oncology Center, Mansour University, a great addition, a great surgeon, and a great laparoscopist as well. Dr. Khaled was humble enough to accept our invitation today to speak about the surgical management of endometrial cancer, how we are going to deal with endometrial cancer. So thank you, Dr. Khaled, for your time, and the floor is yours. For everyone, sorry, please, if you want to interrupt, just ask, put your questions in the Q&A box or raise your hand and you can interrupt Dr. Khaled, but I believe he has got a long presentation today.
Thank you, Dr. Bassel, for your very kind words. We have a little bit long presentation. I will try to be brief as I can. We'll speak mainly about the surgical management of endometrial cancer. As you know, that endometrial cancer is the most common gynecologic malignancy in the Western world and the fourth common cancer in females. The standard cost-effective value-based approach to endometrial cancer depends upon main three items: the diagnosis, depending on the histology from the DNC or the hysteroscopy, clinically assessing the probability of metastatic disease based on histologic type and grade. The third one, the surgical management, hysterectomy with or without lymphadenectomy or omentectomy, and etc. So to go in the core of the topic, until now we know that there is two different subtypes of endometrial cancer: type 1 neoplasm, type 2 neoplasm, and also there is the recent genetic molecular profiling of the endometrial cancers, as was presented by Dr. Bassel last week. We'll speak first on the old subtypes, because until now in the most of the guidelines in the ESGO and the NCN, the guidelines are applied on these subtypes, because we as Dr. Bassel said last week, that the paradigm of course will change, but it will take some time to implicate the molecular typing upon the clinical treatment and management of this case. So the type 1 neoplasm, as most of you know, are low-grade adenocarcinomas, grade 1 and grade 2 mainly. These tumors are mainly estrogen sensitive, associated with obesity, usually preceded by endometrial hyperplasia, atypical endometrial hyperplasia, usually present at early stages, usually have a very good prognosis. Okay. The type 2 neoplasm, they include the FIGO grade 3 endometrial cancers. There are endometrioid histologies like the serous, the clear cell, the mixed cell, and the undifferentiated, and the carcinosarcoma. These neoplasms are mostly not estrogen sensitive, not associated with obesity, often occur in the presence of atrophic endometrium, high grade, and have poorer prognosis. This is a recent molecular typing that was presented by Dr. Bassel last week. The main four types, the POL-E, and the after we do the POL-E sequencing, which we don't have in Egypt now, we can do the MMR if it is deficient or proficient. If it is deficient, it will be deficient MMR. If it's proficient, we will go for P53 immunohistochemistry, which give either P53 mutant or non-specific molecular profile, which is similar to the low grade. This molecular profiling, until now, it's not clinically implicated in all the guidelines. So we'll speak mainly about the type 1 and type 2 neoplasm. Also, the staging. Until now, we are nearly sticking to a FIGO staging 2009, and we are trying to shift now to the new FIGO staging in 2023, and it have really some clinical implications now, and we will discuss them in the following slides. ممكن نتكلم عربي شوية؟
I believe we have more than 4 or 5 4 or 5 non-Arabic speaking
Okay.
attendees.
Okay. So we will speak about the surgical management. I was trying to tell Dr. Basil that please, I would be sorry if I put some Arabic words in the middle of my talk. So forgive me for this. Endometrial cancer is mainly surgical staged. The core for treating endometrial cancer is mainly surgery. The staging procedures include the hysterectomy, the oophorectomy, plus or minus the lymphadenectomy or omentectomy according to the histological subtype and the staging of the disease. Okay? So the goal of the surgical management is mainly remove the primary tumor for the curative intent, and the second, the identification of the prognostic factors to determine whether adjuvant therapy is required. Like in the lymphadenectomy, we do the lymphadenectomy mainly for not for curative intent, but for staging intent. Like if we find the nodes positive, we can give a radiotherapy. If they're negative, we can omit the radiotherapy, and that's how it goes. So we speak mainly about the apparently confined uterine disease, which is most cases and most of our lecture, and the advanced disease. Okay? In the apparently confined uterine disease, the surgery with hysterectomy and salpingo-oophorectomy is the mainstay of our management of endometrial cancers. We will speak about the approach. Most of our cases are mainly type 1, most of our cases have a favorable prognosis. The approach for surgery to endometrial cancer has evolved significantly towards the minimally invasive techniques. Minimally invasive surgery is recommended for patients with disease apparently confined to the uterus, who are surgical candidates and whom procedure is expected to be able to be completed without conversion to laparotomy. This is based on consistent data from a number of randomized trials that we will discuss now. As you see, this is a photo from our patient here in Egypt. Most of our patients have a high BMI more than 40. So as you see an abdomen like this, of course, it's much better to go towards the minimally invasive technique. If you open a case like this in midline, all of us will have troubles. We and the patient and the surgeon and everyone. كلنا هنعاني يعني. So one of the main and core trials in this part of the Lab 2 study, which was nearly published in 2009. The Lab 2 study assigned about 1,696 patients with stage 1 and 2 uterine cancer to laparoscopy and about 920 patients to laparotomy. They found that the patients in the laparoscopy group had similar rates of intraoperative complications with longer duration, we'll tell you why, but fewer moderate to severe postoperative adverse effects. The hospital stay of no longer than 2 days was significantly lower in the laparoscopy group. And the one concern that, as we say, that the laparoscopy group had a much longer time that 25% nearly of these patients were converted to laparotomy. That was mainly dedicated that this was about 20 years ago. Most of the surgeons were in the beginning of their learning curve skills. So it took from them much more time and it took from them much more conversion. And these numbers, I think nowadays are much more or less. Okay. So the most important point was the follow-up data from Lab 2 about the survival and the oncologic outcome, which is the main benefit of this technique, that we have a similar survival for patients who underwent either laparoscopy or laparotomy. And the estimated 5-year recurrence rates were also similar between the laparoscopy and the laparotomy. Also, the quality of life assessments were superior in the laparoscopy group in many measures, like the physical functioning, body image, less pain, and etc. This is the survival and recurrence between both groups in the Lab 2 study, nearly identical between the open and the laparoscopic group. And of course, the laparoscopic group had much more favorable post-op sequelae. So another well-known trial is the LACE trial. The LACE trial, which is called the laparoscopic approach to the cancer of endometrium, was multinational randomized equivalence trial between 2005 and 2010, in which 27 surgeons from 20 tertiary gynecological cancer centers all over the world were encountered in this trial. The trial, the final results for the follow-up of the survival was published in 2016. They randomized 706 women with stage 1 endometrial cancer to either laparoscopic hysterectomy or abdominal hysterectomy. Okay. We found that no difference in the disease survival at 4.5 years or overall survival between the two groups of the LACE trial. Another large retrospective Cochrane study of about 3,640 patients found that was published primarily in 2012, and the follow-up of this data was republished again in 2017. They found that no difference in the risk of death or recurrence between the patients who underwent laparoscopy compared to laparotomy. And in two separate sub-meta-analyses, there was less blood loss with laparoscopy and fewer severe postoperative adverse effects, like it's all known by all other trials. The update of this Cochrane review, which was published in 2012, was published about 4 or 5 years later. They added some studies, and they also followed up the overall and disease-free survival of these patients. 6 studies assessed nearly 4,000 patients with early-stage endometrial cancer, found no significant difference in the risk of death between women who underwent laparoscopy and women who underwent laparotomy. 5 studies assessing about 3,700 patients found no significant difference in the risk of recurrence between the laparoscopy and the laparotomy groups. And one meta-analysis of 3 studies found that women in the laparoscopy group lost significantly less blood than women in the laparotomy group. A further meta-analysis of 2 studies, which assessed about 3,344 women and included one very large trial of over 2,500 participants, found that there was no clinical difference in the risk of severe postoperative complication in women in laparoscopy and in the laparotomy group. So all of these trials are speaking about that we have a similar survival rate, we have a similar disease-free survival rate, and you have a much, much more better post-operative outcome in the laparoscopy group. But most of these trials were speaking about the low-risk tumors, the type 1 tumors. So for the high-risk disease, what shall we do? Can we go also for minimally invasive surgery or not? We have a number of trials. We'll start with this one published in 2016. That was a multi-centric database compared the disease-free survival and overall survival between 114 patients with the high-risk histologies only, not the early stage or the type 1 cancers, who underwent surgical staging via minimally invasive surgery, and other 114 who underwent through laparotomy. With a median follow-up time of about 49 months, the disease-free survival and overall survival were not significantly different between both the surgical cohorts. صحيين ولا نمتوا ولا ايه؟ Okay. Another study, a multi-center study performed in Argentina, retrospective cohort study of about 24 centers, included the patient with high-risk endometrial cancers. They found that minimally invasive surgery was not associated with worse disease survival at 4 years of follow-up. Another large study performed by, I think this was by a Korean group, I think. Moment. 9 observational studies fulfilled the research criteria for this. They found that the minimally invasive surgery didn't significantly increase the risk of recurrence when compared to the open surgery techniques. This pattern was also observed in a subgroup analysis based on the stage, histology, and the minimally invasive type, whether laparoscopy or robotic. This one, with a large systemic review, a very interesting one between the Italian and the American groups, included the patients in the Mayo Clinic from 1999 to 2016. The systematic review identified about 2,300 patients. The articles were included if reporting original data on overall survival and the disease-free survival among patients with the high-risk endometrial cancers. The meta-analysis found that disease-free survival and overall survival in patients with high-risk endometrial cancer who underwent minimally invasive surgery were not statistically different from those of patients who underwent open abdominal surgery. Subgroup analysis by stage didn't identify a difference between the surgical approaches. Those minimally invasive surgery and open surgery had a similar disease-free and overall survival in patients with high-risk group also, high-risk endometrial cancer. Also, a large retrospective study from the National Cancer Institute in America, National Cancer Database, identified a cohort of women who underwent hysterectomy for type 2 endometrial cancer between 2010 and 2014. The primary outcome was a comparison of the overall survival for minimally invasive surgery with that of open approach. Secondary outcomes included comparative length of hospital stay, readmission, and something like this. They identified about 13,000 patients with type 2, stage from 1 to 3 endometrial cancer that underwent hysterectomy. In total, 7,000 of these women underwent minimally invasive surgery, the rest were laparotomy. They found that the laparotomy group had a higher rate, the laparotomy group had a higher rate of carcinosarcoma histology, stage 3 disease, and larger primary tumors. So the laparotomy group were a little bit more advanced, okay? The lymph node dissection was more commonly performed in the minimally invasive group. With regard to adjuvant therapy, subjection to postoperative radiation was more common in minimally invasive, while chemo was more common in the laparotomy. That means also the patients who underwent laparotomy was a little bit more advanced than the patient who underwent minimally invasive. The time interval between surgery and the limitation initiation of chemotherapy was shortened in the minimally invasive group. And this is a very, very important point, especially in our country, in Egypt, because most of our patients have a very high BMI, more than 40, more than 50. So the patient with a midline incision, they have a very high percentage of wound infection, seroma, and all of this delay the start of the chemotherapy, which we don't like to delay, especially in the cases of high-grade serous and clear cell carcinoma and like this. So the minimally invasive surgery always gives us a good solution to start chemotherapy as soon as possible. According to the results, this trial found that the minimally invasive surgery was associated with superior overall survival, not like the other trials. Other trials nearly say that they have the same overall or disease survival. This trial found that there was survival benefit in the patients who underwent minimally invasive surgery. But as I told you now, that the patients who underwent laparotomy had a more advanced disease. And of course, it's a point of criticism to this meta-analysis. Okay, that's the survival curve. As we know, it's shaped like the crocodile, as Basil said before. There was a significant difference between the survival, but as I say, also the patients who underwent laparotomy had a much more advanced disease. So the robotic surgery. Nearly we have a very few robotic platforms here in Egypt because it's much, much, much more costly. But we must speak about it because it's present now worldwide. There's an evidence that robotic surgery is associated with similar short-term outcomes, shorter operating room time, lower conversions late to laparotomy, especially in the high BMI patient. It's more easy to operate in a morbidly obese patient with robotic than with laparoscopy. However, in expert hands, we don't find conventional laparoscopic surgery to be inferior to robotic surgery. Given the higher cost of robotics, it remains unclear which cohort of patients derive the most benefit from clinical and cost effectiveness perspective, especially in a country like our country. I think we still cannot go with robotic surgery now because of its cost mainly.
يعمل ايه الروبوت في وطن ضايع.
بالظبط. So this is a trial about the feasibility of robotic surgery. The randomized trial of about 100 patients, robotic versus laparoscopic surgical staging for endometrial cancer, found shorter operative duration for the robotic groups. And there was no convergence to laparotomy in the robotic group. As we said, that the robotic gives you much more confidence to operate on especially morbidly obese patients. There was no difference in the number of lymph nodes removed, the bleeding, or the length of post-operative hospital stay. The rate of major post-operative complications showed no difference between both groups. These are also other trials about the robotic surgery. A database study was published including about 1,000 patients with endometrial cancer underwent laparoscopic hysterectomy, and about 1,500 underwent robotic hysterectomy, also found no difference rate in complication between both groups. So to speak in brief, the robotic has less rate of conversion to laparotomy compared to laparoscopy, but it has a much, much more higher cost. Nearly the same survival benefit, nearly the same post-op complication and post-op morbidity. So the ESGO recommendation, according to the minimally invasive surgery, the minimally invasive surgery is recommended in the surgical management of low and intermediate risk of endometrial cancer. And it's also can be considered in the management of the high-risk endometrial cancers. As it's also stated in the last NCCN guidelines, hysterectomy and lymph node assessment is the primary treatment for apparent uterine confined endometrial cancer, unless the patient desire for fertility-sparing options. Hysterectomy and salpingoplectomy and lymph node assessment may be performed by any surgical route, laparoscopic, robotic, even vaginal or abdominal. The para-aortic nodal evaluation from the inframesenteric and infrarenal regions may also be utilized in staging patients with the high-risk tumors, such as deeply invasive lesions, high-grade histology, tumors of serous carcinoma, clear cell, or carcinosarcoma. With the mental biopsies commonly performed in those with serous clear cell or carcinosarcoma. So, in brief, in the endometrioid adenocarcinoma, in the low-grade early stage, we just do the hysterectomy. In the deeply invasive lesions, we do the hysterectomy and lymphadenectomy. And in the high-risk disease, we do the hysterectomy, pelvic and para-aortic lymphadenectomy, and omentectomy. So a very important point we will speak about as we spoke about the minimally invasive surgery, the use of the
again for the words that
manipulation.
for Amira's nomenclature is not debulking. It is not. This is surgical staging for early endometrial cancer. We do debulking in stage 3 and above. Okay, so if it is low risk, we do surgical staging, and the staging is only hysterectomy, as Dr. Khaled said. If you do more this surgical staging, okay, I'll show you a case, a report of a case after we finish that is upstaged because of this surgical staging. So you do surgical staging, but for the high risk, because they have high risk for nodal metastasis and metastasis, blah, blah, blah. So you do the surgical staging, so you may find something that's omentum in the lymph nodes, and so you upstage your tumor. So this is called surgical staging, not debulking. Okay, and we will have a talk after for one case, because to demonstrate that, and my assistant today wrote it as debulking, and I removed the word debulking, it's surgical staging. Okay. Debulking is when you have advanced tumor and you are going to do debulk this advanced tumor. But in all gynecological cancers, we do surgical staging. Okay.
So we go to speak about the uterine manipulator, which is a really hot topic, always to use or not to use in endometrial cancer. I'll start with a retrospective famous trial from our group in Gemelli by Stefano Uccella. They reported a study about of 1,000 patients, 579 patients in the manipulator group and 372 in the no manipulator group. After a median follow-up of 46 months, the rate of recurrence was nearly the same between both groups. They concluded that the use of the manipulator didn't affect the risk of recurrence between both groups. Disease-free, disease-specific, and overall survivals were similar between both groups. Another study that was the prospective one of the most famous prospective one in the use of uterine manipulators was the Romani trial, published in 2021 by also Salvatore Giulialetti from Policlinical Gemelli in Italy. In the study, 154 patients, 76 in arm A and 78 in arm B, were use of manipulator or not use of manipulator. No difference were detected in the terms of overall survival and disease-free survival between both groups. No statistically significant differences were recorded between the two study groups in terms of peritoneal cytology, lymphovascular space invasion, and the pattern of lymphovascular space invasions. Similarly, no differences were recorded in the number of recurrences between both groups. They stated that the use of the uterine manipulator had no impact on disease-free survival, both at univariable and multivariable analysis. So this was another Spanish trial published nearly in 2020 about the use of the manipulator. That was a large retrospective study. Total of about 2,600 women from 15 centers were included. About 1,700 patients used a manipulator and 905 without it. Both groups were balanced with respect to the histology, the tumor grade, the myometrial invasion, the FIGO staging. We found that the rate of the recurrence was higher in the uterine manipulator group than the non-manipulator group, and that was statistically significant. We stated that the use of uterine manipulator was associated with a worse oncological outcome in patients with uterus confined endometrial cancer who underwent minimally invasive surgery. prospective trials are essential to confirm these results. And that was the result of this meta-analysis. We found that there is a significant difference in survival between the no manipulator and the manipulator group. As you said, the Italian group said that you can use the manipulator, and the Spanish group said you cannot use the manipulator. So the Italian group have also a reply for the study of the Spanish group about the use of the manipulator. They stated that should be noted that all previous literature reported no difference in clinical outcomes, whether or not the manipulator was used in endometrial cancers. Most of the previous studies were largely underpowered, as we know, to detect small differences. However, the Italian group stated that they had a retrospective study that we showed now for about 1,000 patients, and they had also the Romani trial confirming their outcomes, that no difference between the manipulator and no manipulator group. And they stated had some criticism to this trial that was heterogeneous population of patients. About 10% of patients had the cervical stromal involvement, vaginal or adnexal involvement, nodal involvement, and this, of course, may have had an impact on the results. Patients with frank cervical involvement may benefit from avoidance manipulation of the affected cervix. We don't know that if all these patients didn't use the manipulator. Of course, if you use the manipulator with cervical involvement, it's much, much more worse. So they also have some questions about the study that was it homogeneous among the different centers when the manipulator was not used with was there any vaginal device pushing the cervix to obtain cranial traction of the uterus? If yes, was this device used in all cases or not? This information would be important, particularly in those cases with caudal spread of the to the cervix. So the fight continues between the manipulator and the non-manipulator group. So the Gemelli group also published the large systematic review, I think about 1 or 2 years ago, about the influence of uterine manipulator after the Spanish group published data in 2020. انتوا معايا ولا فصلت؟ The systematic review included 18 studies. The pooled results showed no significant difference in the incidence of lymphovascular space invasion between the manipulator group and the non-manipulator group. No significant difference in the rate of recurrence was found. But we found a positive association between malignant cytology and the hysterectomies in which a manipulator had been used to a subgroup analysis where laparoscopic hysterectomy, laparoscopic assisted vaginal hysterectomy were compared to abdominal hysterectomy. So it maybe it didn't influence the survival, but it influenced the peritoneal cytology. Last year, or I think that this was published recently, last year or this year, I don't remember, from a large study from Japan, from a Japanese group. A study population was about 3,800 patients who had a laparoscopic hysterectomy for endometrial cancer from 2015 to 2017. Okay, survival outcomes were assessed by accounting for possible pathological mediators related to the intrauterine manipulator use. What did they find? They find that the incidence of lymphovascular space invasion in hysterectomy specimens were 17.8 when we used the manipulator and 13.3 in the non-manipulator group. They found that the intrauterine manipulator use was associated with 35% increased odds of lymphovascular space invasion. The instance of malignant cytology identified in pelvic peritoneal cytologic sample at hysterectomy were 10.8 for the manipulator and 6.4 for the non-manipulator group. They found that the manipulator use was associated with 77% increased odds of malignant peritoneal cytology. But for my surprise, that the 5-year overall survival rates were nearly the same between both groups. So the manipulator may increase the possibility of post-peritoneal cytology, but at least in the literature now, we don't have a solid confidence that it may impair the survival. But I think if you don't feel comfortable with the manipulator, you can use this. You can use gloves with the gauze inside to push the uterus for you. It's a very good solution without taking any risks. So for the manipulator, the fight still goes. We don't have enough solid data that it impairs the survival. If you want to use it, you can use it. But my preference that even if you use it, try to avoid using it in a little bit advanced cases, the cases with type 2 endometrial cancer with the uterus huge, fleshy. If you are unaware there is cervical involvement or not, cervical involvement or not, I think you should better to avoid it. تمام؟ ايه؟ ماشي اوكي، بس هو في الاخر زود السرفايفل في اسرع سرفايفل ولا لا لغايه دلوقتي؟ لا، بس في اكتر من ترايل بتقول ان هو زود الليمفوفاسكولار سبيس انفيجن. لو عمل اب ستيجنج بس.
هو دلوقتي الليمفوفاسكولار سبيس انفيجن داخل في ال classification صح في الفيجو 2023 classification بتاعت الاندوميتريال كانسر ان هو substantial lymphovascular space invasion ولا non substantial او no او focal ماشي. فلو انت كده if we're increasing it زي ما عمرو قال ان احنا كده it makes a difference في ال adjuvant treatment.
according للنيو كلاسيفيكيشن ممكن فعلا لو زود الليمفوفاسكولار سبيس انفيجن ممكن يفرق في الادجوانت تريتمنت.
Have you seen our fellows?
اه
Our gynecologist saying to you, focal and substantial lymphocyte space invasion, yes or not, according to the new FIGO. I'm proud of you, Amira. Really, I'm proud.
So we continue. We spoke all of the post slides we are speaking about the minimally invasive techniques. So this is a laparotomy if you'll go for laparotomy. For patients who are surgical candidates with disease apparently confined to the uterus, but in whom minimally invasive surgery is not feasible due to if it have an excessive uterine size, maybe the patient inability to tolerate the deep Trendelenburg position. That happened also in some of our patients who have morbid obesity. They cannot tolerate the Trendelenburg position. If we have an advanced disease, uterine disease, and we're going for a debulking or site reduction, as Amira said before. And the fourth one is the surgeon skills. That's one is important one because we don't want to omit para-aortic lymphadenectomy because I cannot perform it by laparoscopy, or we do not want to omit the pelvic lymphadenectomy because I cannot do it by laparoscopy. You should think in the beginning by the oncological way. What should the patient have to be done for her? So you should do it, whether by the laparoscopy or the laparotomy. If you cannot do it by the laparoscopy, do it by the laparotomy. Laparotomy standardly is done through a midline incision. That is the appropriate surgical approach. But also for the apparent early stage endometrial cancers, especially in the morbidly obese patients, you can go through phalangeal incision. And we do this in many of our patients. As you see, an abdomen like this, it's much, much more better if you're not go by laparoscopy to go by phalangeal incision. Also, we can use the vaginal hysterectomy. We as a surgical oncologists, we are not so familiar with it, but it's a very, very good solution in the cases, the low-grade, early-stage cases where you don't have to enter the abdomen to do a lymphadenectomy or something like this. You can go for vaginal hysterectomy, which has also a much, much lower cost than the laparoscopy. In the cases for cervical involvement, the surgical management, what will be the surgical management? We can do a simple hysterectomy followed by radiotherapy, or you should do a radical hysterectomy, type B or type C, followed by radiotherapy. I found the last sentence written in the up-to-date. It's really strange for me that you can give primary radiation followed by extrafacial hysterectomy, which I didn't see before. Okay.
No, and the field would be very bad.
Yes.
to the population.
So I just put it because it's written up to date, but I didn't see this practice in the hospitals where I worked in. So sometimes we're speaking about do you do a radical hysterectomy or not to do a radical hysterectomy. Given the absence of a prospective comparison, these treatment approaches, the management of patients with disease extension to the cervix must be individualized on the patient pathologic and provider factors. Individualized decision each patient if he had a cervical involvement. For patients with a normal clinical examination, but with endocervical curettage post of endometrial cancer, extrafacial hysterectomy followed by radiation is generally the recommended treatment type. You don't need to go for type C1 or type B2 hysterectomy. So this is for the hysterectomies, and we have also, we'll speak about it again in the last few slides for the lymph node evaluation. The lymph node evaluation in general, the options for management of retroperitoneal lymph nodes are one of these four. You will not do a lymphadenectomy at all. You will do a lymphadenectomy in all the patients. You will do a sentinel lymph node in all the patients. You will do a systematic lymphadenectomy only if you have a high-risk patient. So we have to choose from these four routes.
So
We do,
it's clear we don't have what's called lymph node sampling or cherry picking. Okay? Because
yes,
I found this written several times. We don't do sampling. We do either systemic lymphadenectomy or we do sentinel lymph node. Okay? Okay.
So to speak in a historical way, the approach for the lymph nodes, the surgical management of the lymph nodes has changed dramatically in the last 3 or 4 decades. Prior to the 80s, the lymphadenectomy was nearly not performed. Then, after that, in the 80s, when they found that factors that some patients had an increased risk of lymph node metastasis, the paradigm changed that they nearly did a lymphadenectomy to all the patients. And they found this is much, much more morbidity. After this, they found that most of the majority of the patients who underwent lymphadenectomy had no lymph node metastasis. So they began to think to change the paradigm again from the routine, complete pelvic and para-aortic lymph node dissection to a much limited or selective lymph nodal dissection. A number of trials emerged, like this trials and the ASTIC trial. They stated that the first trial was about 500 patients with clinically stage 1 endometrial cancer assigned to systematic pelvic lymph node dissection versus the cherry picking or removal only of no, not cherry picking. They removed only if there was positive nodes, they do the lymphadenectomy. A median of 30 nodes were removed and adjuvant therapy was provided at the discretion of the treating clinician. Fewer patients received adjuvant therapy in the lymph node group than the control group. They found that after 49 months, the systematic pelvic lymph node dissection compared with the removal of the only enlarged nodes, which was in high-risk groups, had compared hazard ratios for relapse and death. The ASTIC trial, that was also a famous one, of about 1,500 patients with stage 1 and 2 endometrial cancer were assigned to systematic pelvic lymph node dissection versus removal of lymph node only if suspicious in the high risk or the type 2 cancers. A median of 12 lymph nodes were removed, and the second randomization to the radiation versus observation was performed in a subset of patients, regardless of the status of lymph nodes. After 37 months of follow-up, we found that the removal of suspicious lymph nodes compared to systematic lymph node dissection showed no difference in overall survival and recurrence-free survival. So the challenges to design of these studies and the quality control of the surgery has led many surgeons to discount these data and wait for clinical trials to address these limitations, that we don't need to do lymphadenectomy on all of our patients. In addition to the lack of evidence of therapeutic benefit of lymph node dissection, less invasive techniques have become standard of management, like the minimally invasive techniques. The technique for lymphatic mapping and sentinel lymph node dissection had been refined and had been much, much more famous. As we know that nearly in the surgical or the oncologic world or worldwide, from about 40 or 50 years, we're very, very radical. Now we're going to be much, 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 much conservative as we can. The sentinel lymph node dissection has been the subject for enthusiasm for many gynecologic oncologists and is supported by organizations as the NCN guideline, the SGO, the SGO. This is the FARGE trial, a multi-center perspective, very famous trial about the using the sentinel lymph nodes that was conducted between 2012 and 2015. The sentinel lymph node mapping was complete. Pelvic lymphadenectomy was done in 340 patients. Para-aortic lymphadenectomy was done on 196 of these patients. About 300 patients had successful mapping of at least one sentinel lymph node. 31 patients had positive nodes, 36 of whom had at least one mapped sentinel lymph node. So they stated that yield a sensitivity to detect node positive disease of about 97%, a negative predictive value of about 99.6%. So what are the factors that will determine that we will do a lymphadenectomy or not? Mainly the probability of the lymph node metastasis depending on the disease stage or type. The feasibility of surgically assessing the nodes, that's very, very important. That will you surgically be able to assess this node? What I mean that a patient with a BMI 56 and she has a high risk disease, will you do, and she cannot tolerate a Trendelenburg position to do a laparoscopy, will you do an open midline incision and do a paraortic lymphadenectomy? If you omit it, I will not criticize you. Yeah. The risk and acceptance of the risk of lymphedema, that's much more common in Western countries. Here we don't have this ما عندناش الثقافة دي قوي يعني. Okay, but this is something that have to be concerned in our patients. The acceptance rate of use of adjuvant therapy. What do we mean by these last two sentences? That patient should be counseled about the options and engage with the surgeon in the shared decision for lymphadenectomy. Like some patients, they don't want lymphedema, so they want to avoid the lymphadenectomy at all costs. And they may take adjuvant therapy prophylactically, like radiotherapy after the operation, instead of doing the lymphadenectomy. And also vice versa. Thus, if you do a lymphadenectomy with a negative nodes, you will not have a post-operative radiation like in stage 1B endometrial cancers. So the aortic lymph node dissection, the decision to dissect aortic lymph nodes based on data suggesting that there is a risk of aortic metastasis in the presence of pelvic lymph node metastasis. Isolated aortic lymph node recurrence may occur. Survival improved when aortic lymph node dissection included with pelvic lymph node dissection. That's very questionable. So identification of patients at lower risk for aortic metastasis has led many surgeons to omit the aortic lymphadenectomy when the risk of metastasis is predicted to be lower than the procedure to remove the lymph nodes. In practice, when performing a lymphadenectomy, most surgeons perform a pelvic dissection and a selective aortic dissection based on feasibility of completing the procedure safely. As we said, the patient is much more morbid obese. The surgeon have a risk to go in this area. He may omit the para-aortic lymphadenectomy. So as we see it in the NCCN guidelines, the para-aortic nodal evaluation from the inframesenteric infrarenal lesion used only in staging of the high-risk tumors, like the high-grade histologies, deeply invasive lesion, tumor with serous cancer, clear cell, or carcinosarcoma. Excision of suspicious or enlarged lymph nodes in the pelvic aortic region is important to exclude nodal metastasis. Some patients may not be candidates for lymph node dissection, either for comorbidity, for morbid obesity, or etc. This is one of my patients I did by laparoscopy, that we have did laparoscopic para-aortic lymphadenectomy in a high-risk disease up to the renal vein. So to finalize the lymphadenectomy, which patient will do a lymphadenectomy, which patient or not? To speak in brief, type 2 neoplasm, including grade 3 endometrioid cancers, high-grade histologies, serous clear cell carcinosarcoma, and the undifferentiated, that will do a lymphadenectomy. The deeply invasive tumors, including 1/2 or more of the metrium tumors, will do the lymphadenectomy. The large tumors and preoperative imaging also will do the lymphadenectomies. We have the main criteria to exclude the patient who will not do a lymphadenectomy, which is a grade 1 or 2 endometrial histology, tumor size 2 centimeters or less, 50% or less myometrial invasion. So these patients can omit the lymphadenectomy, and the rest of patients will go to the lymphadenectomy. The high-risk disease will do the para-aortic with the omentectomy. The intermediate to high-risk group may be sufficient to do the pelvic lymphadenectomy. Sorry. I will go for the sentinel lymph node dissection for the sake of time. The sentinel lymph node dissection following lymphatic myopia has become a standard option for the management of the retroperitoneal lymph nodes in endometrial cancers. As you see, you are going more conservatively to select the patients. So if we have the solution of sentinel lymph node dissection, why not we use it even in all cases? We'll speak about this now. In a study based on surveillance, epidemiology, and SEER database, including about 83,000 patients with endometrial cancer undergoing surgical management, utilization of sentinel dissection increased from 0.2% in 2005 to 30, nearly 30% in 2018, and I think these numbers are much more increasing. increasing utilization of sentinel lymph node dissection was not associated with an increase in cancer-specific mortality compared with complete lymph node dissection. This is a very important sentence. So we can spare the complete pelvic lymph node dissection even in the high-risk group with the sentinel lymph node biopsy. عندنا رسالة جديدة أعتقد سمر داخلة رسالتها في نفس القصة دي. Data supporting the use of sentinel lymph node dissection include prospective and retrospective studies showing increased detection of lymph node metastasis and the low false negative rate compared to systematic lymph node dissection. The NCN, the SGO, and SGO support the role of sentinel lymphadenectomy in the management of patients with endometrial cancer. We use the ICG retrospective data suggests that the ICG alone or in combination with other tracers superior to that of blue dye alone. I think we tried this also here in our center. We tried the blue dye, which the results was not that good. In a meta-analysis including 33 studies evaluating the diagnostic accuracy of various tracers of sentinel lymph node assessment in patients with early stage, ICG used alone in combination with blue dye appear to have a higher detection rate compared with the non-ICG tracers. That was mainly in the early stage endometrial cancers and the low risk group. Now, the high risk group endometrial cancers, we have a number of studies that speaking about the visibility of the use of sentinel lymph node dissection in the high risk groups instead of doing systematic pelvic and the para-aortic lymphadenectomy. Even here in the new NCN guidelines, recent evidence indicates that sentinel lymph node mapping may also be used in high-risk histologies. As we say, we are going in the oncology to the much more conservative treatments for the better quality of life, for the better post-operative sequelae. So how to do the sentinel lymph node dissection? Nearly you inject at 2 sites at 3 o'clock and 9 o'clock. You inject a superficial and 1 centimeter deep at 3, superficial and 1 centimeter deep at 9 o'clock. You wait for about 15-20 minutes. And this was done here in UCMO about 2 years ago. This photo, Dr. Basil, I think, did it with his phone. That was a first sentinel lymph node to be done here in UCMO. And I was proud to be the one who did it. And that's for the lymphadenectomy. Okay. For the type of hysterectomy that we spoke in some of our previous studies, slides, where there's cervical involvement, you will do a radical hysterectomy or not. Simply, it's this sentence. For stage 2 patients, hysterectomy bilateral major operectomy is the standard procedure, which is a simple hysterectomy type of procedure. Radical hysterectomy should be only performed if needed to obtain negative margins. It happens that after you enter, maybe you find some minimal parameter infiltration. So you should go more lateral. You can go to type B hysterectomy or type C hysterectomy to have a negative margins of resection. Otherwise, you can stick to type A followed by radiotherapy. Okay, for the advanced stage disease, all of we spoke about with the early stage disease, we're speaking about the surgical staging to know the stage of the patient. We are doing lymphadenectomy to know if the patient will be upstaged or not, they are positive or not. We are doing the omentectomy to find it's positive or not, to know if the patient are upstaged or not. But if the patient have an advanced disease from the beginning, how will we how will we deal with this type of patients? In patients who have a clinical or radiographic evidence of metastatic disease, surgery is typically performed to
Yes. So Dr. Khaled just is going to have some water. 50 minutes. Yes, you have 10 minutes to finish. 12 minutes.
We have to establish a diagnosis, palliation of symptoms and standard disease if it is an advanced disease, and improve the oncologic outcomes. Why improve the oncologic outcomes? Because mainly in the high risk endometrial cancers, it's like behaves like the ovarian cancer cases that you are doing a cytoreduction or a debulking. If you can achieve an R0 or CC0 section, it have a much more better survival outcome in the patients. So this is an important 2 or 3 slides about the new FIGO staging and the implementation it on the clinical and the adjuvant therapy, as you said before. Synchronous ovarian endometrial cancers. Synchronous primary cancers of endometrial and ovary are found in about 5% of the patients with endometrial cancer and 10% of the patients with ovarian cancer. For the patients with endometrial cancer, the risk appears to be higher in premenopausal women than the postmenopausal women. It may increase from 5% to 29% that they have a synchronous ovarian malignancy with the endometrial cancer. So, for patients with ovarian involvement, the following criteria are used to distinguish those with limited to low-grade endometrioid carcinoma. This is important because it's implemented in a new FIGO staging, and it will change the adjuvant therapies in the number of patients. If the patient have invasion of less than 50% of the myometrium, it's a low-grade endometrioid, no extensive substantial lymphovascular space invasion, no additional metastasis. Of course, the manipulator may have an impact on this. Ovarian tumor is unilateral limited to the ovary without capsule invasion and or rupture. So, in these cases, they will be, even if they have an ovarian involvement, they will be 1A3. In the previous FIGO staging, it will be stage 3. And if they have an extensive or high-grade metastasis to the ovary, they will be stage 3A. So this is a big difference. Histology is often the same for both groups, making it unclear whether there are two separate primary tumors, metastasis from the endometrium to the ovary or from the ovary to endometrium. However, the prognosis and management will differ, and that's a very important point. Patients with low-grade endometrioid involving the endometrium and ovary have a good prognosis and are not typically treated with adjuvant therapy. The patient may go on a follow-up. She may not have an adjuvant therapy. On the otherwise, the patients with high-risk disease, high-grade disease with extensive spread of endometrial carcinoma to the ovary may have more severe disease and are typically treated with adjuvant therapy. So that is a very big difference. Given that young patients with endometrial cancer may be candidates for ovarian preservation, recognition of risk for synchronous ovarian cancer in this population will facilitate the shared decision-making. Additionally, young patients should be assessed for their potential risk for having developed their endometrial and or ovarian cancers as a result of Lynch syndrome, since the safety of fertility preservation in this setting of genetic mutation is still unknown if the patient have a Lynch syndrome. We are about to finish. So in recurrent disease, does the surgery have a place? Yes. If you have a local original disease and the patient especially had a prior radiotherapy, maybe if it's an isolated recurrence and you are sure of that by PET scan and etc., you can go for the surgical resection, followed also maybe by radiotherapy. So to summarize, the surgery was a hysterectomy, and saphenophractomy is the mainstay of the management of endometrial cancers. Lymphadenectomy and endometriectomy may be added in the cases with high-risk disease. Minimally invasive surgery is recommended for patients with disease apparently confined to the uterus who are surgical candidates and whom the procedure is expected to be able to be completed easily without conversions. Minimally invasive surgery is recommended, especially in obese patients, to avoid one complications. And this is very important to shorten the window between the surgery and adjuvant therapy, as we see in many patients here of our obese patients. When they have a big incision, they usually go into seroma, post-orthodontic infection. They have a delay of the adjuvant therapy. Minimally invasive surgery can also be considered in cases of high-risk disease. The defibrillator may be used with precautions, and paradigm is going to be shifted by the new staging. Hysterectomy for apparent early-stage endometrial cancer through a transverse incision may be considered, especially in morbidly obese patients with low-grade endometrial cancers, and also vaginal hysterectomy can be considered in these patients. Lymphadenectomy will be omitted in low-risk patients. If you don't have a sentinel lymph node, because the ICG is still very, very rare in Egypt, so lymphadenectomy should be considered only in type 2 endometrial cancers and cancers with deep myometrial invasions and larger tumor size. If you have a sentinel lymph node, it should be considered in clinically nodal negative patients, even the high-risk group. The NCN, SGO, and SGO support the role of sentinel lymphadenectomy even in patients with high-risk group. And thank you.
Thank you so much, Dr. Khaled. And we have some questions from our audience. Dr. Mohammed Zuhairi, I believe you know Professor Mohammed Zuhairi, of course. Dr. Muhammad was the ex-head of gynecology unit in NCI, and he's usually participating with us, and he's asking about how to treat vaginal cuff recurrence.
As we spoke in the one of the last slide, the vaginal cuff recurrence, if the patient didn't have prior radiotherapy she is not metastatic and is isolated recurrence, she can go for radiotherapy. If she's previously radiated and we are sure by PET scan that there is no mets, we can go for surgery.
Yes. And of course, Dr. Muhammad, now in the era, of immune therapy, now we have a place for treating, because if I'm going to treat the vaginal cuff recurrence, if she had received prior radiotherapy, I usually would counsel her about the possibility of exentration, not only due to the tumor infiltration, but also due to the radiation therapy effect. So we will tell her we will have to do a delineate with MRI, be sure that there are no metastases, the relations with the bladder and the rectum, and then she will be counseled if she have received prior radiotherapy that she may have a total exentration, anterior exentration or posterior exentration, either to excise the tumor completely, or even with the best hands and best surgeon with the fibrosis of radiation, you can have an injury for the bladder or for the rectum. Dr. Sumaya, you had a question, you were raising your hand. Do you want to ask a question or not yet? She's saying that it is informative lecture, thanks, from Dr. Sumaya Nagy. And there is an anonymous attendee saying, in case of endometrial adenocarcinoma on top of endometrial polyp, how to stage such a patient to consider adjuvant therapy? And totally, this would be answered next week by Dr. Ghada Izzat, okay, because it's a totally new staging. According to the new staging, I had just a case of endometrial serous carcinoma on top of a polyp 3 weeks ago, and that was a very informative talk with the patient and their son. So this would be discussed thoroughly with Dr. Ghada Izzat next week. I believe you will be here next Wednesday at 9 p.m. And Dr. Tariq Al-Hawari is asking how to treat endometrial carcinoma in infertile woman who needs to conserve the uterus. And this is my lecture. That would be the next. That would be in the second Wednesday of September. So you should stay following us, because next week the advanced and recurrent, and then we will have sarcomas with Dr. Muhammad Hamdi in the first Wednesday of September. And then my lecture would be about fertility preservation in endometrial cancer in the next Wednesday of September.
I revised the schedule so that I found this that you'll speak about the fertility sparing. So
Yes.
I deleted all the slides of the fertility sparing
Yes.
from my presentation.
Yes, so this will be answered. We will not answer right now to keep you connected with us and delineated with us for the next weeks. Does anyone have other questions? Dr. Amr has a question.
Thank you, Dr. Khaled. Your lecture targeted about the point. I have two questions. First one, if I do Sentinel lymph node, I'm found it's positive. Para-aortic lymph node must be done lymphadenectomy or not. Second question, if I don't have blue dye or ICG and do pelvic lymphadenectomy, do you recommend the frozen section for lymph node to get the para-aortic or not?
Well, in the endometrial, we are differing from the cervical cancer. In cervical cancer, if you do a para-aortic lymph node and it's positive, mostly will close and you will go for definitive chemoradiotherapy. But in the endometrial now, we are speaking about the high-risk disease. It showed that if you found it's positive, I think you will complete the lymphadenectomy in the para-aortic and the pelvic area. For the other question, it will be, I think it will be something individualized and institutional for the patient, that if you do the pelvic lymphadenectomy, they can use a frozen section or not, because not all the institutes are familiar with the frozen section. But if we are speaking about here, we are familiar with frozen section, we can do this. We can send the pelvic lymph nodes for frozen section. If it's negative, we are not supposed to complete the para-aortic. If you found something positive, I think you should go and complete the para-aortic lymph node dissection.
I believe that if you find a positive sentinel lymph node, you are going to get to irradiate here. You're not going to complete in the endometrial. Yes. No, you are going to irradiate here to give her postoperative radiation therapy rather than doing lymphadenectomy, because she would be radiated if you have a yes, because once you have a positive lymph node, you irradiate post-operative as an adjuvant treatment. So if you don't have a bulky nodes, if you have bulky nodes, you have to remove, okay? Or you have to irradiate from the start. But if Sentinel lymph node is positive, you should go for and I have a complete presentation about lymphadenectomy and gynecology after finishing the cervical cancer module. Lymphadenectomy in ovarian cancer, lymphadenectomy in endometrial cancer, lymphadenectomy in cervical cancer. Dr. Mohammed Zahiri saying that he is preferring to do many abdominoplasty with finish incision in many cases. Sure, of course, doctor, this is best in the morbid obese. I believe you are speaking about the morbid obese patient, and this is usually the best to do panniculectomy and removing abdominoplasty with finish incision. This is the best, really. And you can talk, Dr. Mohammed, if you want. Just unmute your mic, and we would be happy to hear your voice with us. You can tell us your experience in this. Dr. Mohammed Nabil is saying para-aortic up to left renal or inferior mesenteric. Again, this is the low para-aortic and high para-aortic. Dr. Khaled, you can answer this question if you would like to, because this is his essay of Mohammed Nabil. His thesis is asking the para-aortic, do you do it to the left renal or the inferior mesenteric, a high or a low para-aortic?
والله الموضوع ده بيتوقف على البيشنت. لو البيشنت morbidly obese and we have many difficulties to do it, we can stick to the inferior mesenteric lymphadenectomy. If we can go to the infrarenal, we go to the infrarenal, like the case I put in the slide here.
Yes. So again, Dr. Mohammed, please remember that most cases of endometrial cancer have the triad of morbid
But of
obesity
course,
with
I'm
diabetes
sorry,
and hypertension. They are mostly obese. Okay. Even what they say about the serous carcinoma, that it comes usually in the non-obese patient, but in the Egyptian
But-
females who are mostly obese in 60 plus or 70
Of course,
plus.
if you have a bulky node, so you should go behind it, even if
Yes.
it's
Yes. يعني
should be-
الفكره ما تحزقش قوي في الليمفادينكتومي في الاوبيز، ما تحزقش جامد لان you will regret it will not change the prognosis or survival. But you have to do it because it really changes the staging يعني. So Amira, Amr, do you have any other comments? So Dr. Khaled, thank you so much for your presentation. Really, it was very illustrative. I hope that again, endometrial cancer is not a single disease. Endometrial cancer, because it is an easy disease to handle with, so many gynecologists do it just simple hysterectomy, and that's it. And so it is not usually handled in an optimal manner in Egypt, and I believe in the region. So again, if you have a low risk disease, if it is an early disease, you divide into low risk, small disease, no myometrial invasion, no lymph nodes, so simple hysterectomy is enough. If it is grade 1 or grade 2 endometrial adenocarcinoma, more than this, grade 3 invasion of more than half myometrium, lymph node positive, large tumor size, you should do lymphadenectomy. If you have it clear serous carcinosarcomas, you should go to do lymphadenectomy. If you have an advanced disease, you have some place to do debulking, but again, don't do debulking in advanced endometrial cancer, except in the MDT context, because mostly if the patient is not bleeding, if she is not symptomatic, she would benefit more from chemotherapy and now from immunotherapy and pembrolizumab and all this anti-PDL. So thank you all. It was a long night. Thank you, Dr. Khaled. And we will meet next Wednesday at 9 p.m. with Dr. Ghada Azzat, Professor of Clinical Oncology. She's going to be speaking about the metastatic, the advanced and recurrent endometrial cancer management from the clinical oncology point of view. Thank you for being with us so late, and good night and sweet dreams. Bye-bye.